Professor Badi, that you have invited us for this meeting, web seminar. Unfortunately, we cannot be present in Iran. As you mentioned, we have been there a couple of times, and there's a big friendship between our group in Germany and your group in Iran. So my talk is on uncomplicated UTI, new approach for diagnostics and treatment. And we start, of course, with a definition of uncomplicated UTI. Usually we say it is an acute, sporadic, or recurrent cystitis or lower urinary tract infection limited to non-pregnant women without relevant anatomical or functional abnormalities within the urinary tract or relevant comorbidities. This is a definition of the European Association Urology guidelines. Now we come to the further definition. Besides symptoms, there is very often a definition of so-called significant bacteriuria. However, we know that a 10 to 5, there's something wrong. That 10 to 5 is CFU per milliliter, has a high specificity, but a very low sensitivity, about 50%. The best would be about 10 to 2. Now we have new studies. They show even 10 to 1 could be very important and significant. And even in patients with typical symptoms and so-called negative culture, if you use a PCR, you can show that they are E. coli. That means there is indeed no significant bacteriuria anymore. Therefore, the clinical diagnosis becomes much more important. And if we do a clinical diagnosis, we need to look for the symptoms, but that's not enough, because we have also to look for the severity of the symptoms. And so we develop the so-called acute cystitis symptom score in many languages. For example, this is the American one. We ask typical symptoms. First is frequency, second, urgency, third, burning, dysuria, fourth, incomplete bladder emptying, fifth, feeling pain, suprapubic pain, or sixth, sometimes we have blood in the urine. That is a hemorrhagic cystitis. Then, of course, we also have to differentiate other symptoms which might be for complicated UTI. That is back pain or low pain or high fever, or maybe even vaginal discharge in women. Then the next question will also be about quality of life in different situations, in normal activities, in work activities, in social activities, and so on. And then we will ask the women also specific situation, for example, menstruation or menopausal syndrome or pregnancy, of course, or diabetes mellitus. If we use this acute cystitis symptom score, then we compare it with control patients without UTI. Control are green and the cystitis are red. And then you can find, if we summarize the score of the symptoms, then frequency has a high score, 2. 2 means moderate. 1 means low and moderate and severe. And you can see that most of these symptoms are at least moderate: frequency, urgency, and dysuria, and so on. And then if we count all this together, all symptoms together, then, for example, the women with cystitis will have a score of between 10 and 12. And we calculated, if we use 6 as a threshold, then we can differentiate between women with cystitis and controls with a sensitivity and a specificity of about 90%. So that means just by clinical diagnostics, we have 90% sensitivity and specificity. And here, this shows another interesting thing. If we compare sensitivity and specificity, then you can see the different colors means different symptoms, or the red solid color means if I calculate all symptoms together. And you can see the red line is the most line on the left side. And the left side means that is the best balance between sensitivity and specificity. And therefore, the total summary score of all the typical symptoms are the best because they give you 90% sensitivity and 90% specificity. Now, what kind of antibiotics should we use? Here I show you the EAU guidelines again, and they say for uncomplicated UTI, we should use old antibiotics, for example, fosfomycin, nitrofurantoin, pifmethylinam. In German, we even have a very old drug. This is nitroxolene from 1962, and this is still working. What we should not use or think about is cephalosporins, third generation, fluoroquinolones, even in Europe, is not anymore licensed for uncomplicated UTI. And cotrimoxazole in many trimethoprim resistance is high in many regions. And therefore, we should not use it. Just the old antibiotics we can use. Why should we not use cephalosporins and fluoroquinolones? If we use a lot of cephalosporins and fluoroquinolones, the resistance will go up, of course, and we will select resistant pathogens. This is not the case, fosfomycin, nitrofurantoin, pifmethylinam, so much, and also not for nitroxolene. Because this is, everybody knows it, antibiotic consumption will drive antibiotic resistance. Now, we can say that in general, we should use antibiotics. However, it's very interesting that now we have many studies that they said, why do we need antibiotics at all? Is it not possible to use non-antibiotics? And one of the first very well conducted study was a study comparing fosfomycin with ibuprofen 400 milligram 3 times daily for 3 days. And I show you the study. And if we use something like scoring of the symptoms again, then the patient started with a summary score of 6. And after 7 days, both groups had about 1 or below 1. That means they are at 7 days, they are about the same results. However, if you use antibiotics, this is a red line, it's faster. It goes down faster than ibuprofen. And if you compare it, then we can see also that with ibuprofen, we have 5 pyelonephritis in the group, and with the antibiotic only 1. We had gastrointestinal problems, nausea, dysuria with fosfomycin, of course, with antibiotics. But even in 1 patient, we had hemorrhage, gastrointestinal hemorrhage, probably because ibuprofen dosage was too high. So it's not ideal, but a very good idea. Now I show you another study, phytodrug. This phytodrug is using Centauri, Lovich, and rosmarine. And this combination shows a diuretic, spasmolytic, anti-inflammatory, antioxidative, and nephroprotective effects in vitro study or in animal study, or some even in humans, preclinical human study. Now, if this is used, here we have a study, a prospective randomized study, where this phytodrug was compared with fosfomycin, the same you have seen, a so-called phase 3 study. And in this phase 3 study, this the name is canifrone, was used with placebo, fosfomycin, and compared with fosfomycin plus versus canifrone placebo. Canifrone was used for 7 days, and as you know, fosfomycin is used single dose. And now I show you the results. We have a total of about 300 patients, so-called per protocol patients in each group. This is a very high number of patients. And then it is difficult. What kind of main measurement should we take? Because as you know, FDA and EMA, they still think that the eradication of bacteriuria is the most important. But if you use a non-antibiotic drug, it cannot be the most important. And therefore, we decided, because it was a double-blind prospective study, we said each group, if there is a failure, then the patient or the doctor will order a real antibiotic, not fosfomycin, but any other antibiotic. And here we tested, and you can see 90% did not use any additional antibiotic, but 10% in the red group, that is the so-called fosfomycin group, 10% wanted to have an additional antibiotic. And in the phytodrug group, it was 17%. So the difference is 7%. So, and then we calculated there was a non-inferiority if we use a 15% non-inferiority margin. So we could say both strategies, non-antibiotic strategy and the antibiotic strategy, give this non-inferiority results for additional antibiotics. If we use the symptom score, then we can see they start about with the same number of symptoms, mean of 10. And at 8 days, they had again the same number of symptoms, about 2. And it's about the same efficacy, only on the 4th day, the antibiotics were a little bit faster. But what is most important, between the 8th day and the 38th day, there is no reinfection or relapse, neither in the group with fosfomycin nor in the group with the phytodrug. So we cannot say that the eradication of bacteriuria will prevent from recurrence until 4 or 5 weeks. Now here, if we go more in side effects, again, we can see the same as I have shown you before, that we have abdominal pain with antibiotics, and we had a bleeding with ibuprofen. The other side effects are not very important. And we see here also the same with canifrone, with the phytodrug. We had 5 pyelonephritis. Fosfomycin, we had 1 pyelonephritis. So that is 1.5% versus 0.3%. It's not significant, but we have to think about. And we have to think about and inform the patients if we start a treatment, non-antibiotic treatment, and tell the patient that they have to be careful. As soon as they have symptoms of pyelonephritis, of course, we will treat with antibiotics. No question about it. Now, let's discuss whether we need new guidelines, because if the elimination of bacteriuria cannot be the main aim anymore, if we use non-antibiotic therapy, we need other main strategies. And we recommend that the symptom scoring should be one strategy. And therefore, if you want to do a symptom scoring, you need a validated questionnaire. And so, of course, it would be very nice if we also could validate this questionnaire, the acute cystitis symptom score in Farsi, in your language. And if somebody is interested to do that, he should contact me, and we will start this to do this. Then we know that also from the studies that if you use a non-antibiotic therapy or an antibiotic therapy, it does not make any difference on the rate of recurrences. Only patients will get recurrences who have recurrence in their history. Thank you very much for your attention.
Thank you very much, Professor Naber. That was very superb presentation and really interesting. I have a question concerning fluoroquinolones. We usually use fluoroquinolones in Iran to treat cystitis, pyelonephritis, and other types of urinary tract infections. Can you hear me, Professor Naber?
I can hear you very well, yes.
Okay. And I have heard about the problem with fluoroquinolones and adverse events associated with fluoroquinolones. And in the European Union, it's actually forbidden to prescribe fluoroquinolones. Yeah. What type of adverse effects resulted in such decision to actually
why is this forbidden? Okay, it's the main reason is the increasing resistance, and of course we use fluoroquinolones in urology. Still we use it, but in very selected cases, in prostatitis or in when we need it for prophylaxis and so on. That's true, but we want to reduce it as much as possible. You know, of course, with levofloxacin you can have a tendon rupture, and I don't know now the whole list of side effects. Maybe Florian Wagenlehner could answer, because he's also from the ESIU, chairman of the ESIU, where we commented on that. And I think it is at least a good advice to reduce fluoroquinolones if they are not needed. If they are not needed. This is the main message.
Yeah, maybe I can address that question. There is a so-called fluoroquinolone disability syndrome, where we have very severe complications, side effects of fluoroquinolones, such as aortic rupture, such as central nervous systems disorders. These are very rare diseases. On the other hand, we have more frequent ones, for example, tendon rupture with levofloxacin. And the other argument is, as Naber said, is that fluoroquinolones as very broad spectrum acting drugs contribute to antimicrobial resistance. And the European Union, the EMA, has withdrawn fluoroquinolone indications only for selected indications, which is acute cystitis and the prophylaxis. And usually in urology, fluoroquinolones are given for transrectal prostate biopsy prophylaxis. And therefore, for these indications, it has been withdrawn, but there are still very valuable drugs for complicated urinary tract infections, for bacterial prostatitis, and other severe diseases. So we have to keep them and we have to save them.
Yeah.
How about use of fluoroquinolones prior to prostate biopsy? I mean, transrectal ultrasound-guided prostate biopsy.
Yeah, it's withdrawn, so we cannot use it anymore. And therefore, the big question is, if you still do transrectal prostate biopsy, what alternatives antibiotics will you use? And we have performed a large meta-analysis where we included randomized studies. And there are 3 antibiotic substance groups that performed equally similarly as fluoroquinolones. These are aminoglycosides, it's 3rd generation cephalosporins, and it is fosfomycin trometamol, but you have to give 2 doses of fosfomycin trometamol 3 days apart. So these are the alternative antibiotic substances that can be given if you do transrectal prostate biopsies. And in addition, for transrectal prostate biopsy, intrarectal povidone iodine, for example, has shown to be very beneficial, as well as targeted prophylaxis, which means you do a rectal swab prior and see if there are resistant pathogens, and then give the antibiotic according to susceptibility levels. What we have also seen is that most departments, at least urological departments in university units, they change to transperineal prostate biopsy. So we have completely, in our unit, we have completely changed to transperineal prostate biopsy since 5 years. So this is a very effective strategy to reduce infectious complications.
Yeah. All right. Any further questions? Hello?
No, thank you very much,
Okay.
Professor Naber. It's a very good presentation.
All right. So thank you very much.
You're welcome. I think Dr. Amini is disconnected. Dr. Faizabadi, you are mute.
Who's mute?
Dr. Faizabadi. Professor Faizabadi, you are muted. Please unmute.
Yeah, Mohammed. Faizabadi, you are mute.
I think
Hello?
hello, you can start it.
Rainer, ja, ich glaube, du kannst starten.
Okay.
Thank you very much.
You see my slides?
Yes,
Yes? Okay.
yes, yes.
Thank you very much for the invitation. I'm coming from the city of Weimar. It's a famous city with a long cultural tradition in our country. The famous poets Friedrich Schiller and Johann Wolfgang von Goethe live there and work there, and this building is the German National Theater, and we are very proud in Germany that in this National Theater for more than 100 years, the first democratic constitution take place in Germany. But now I want to tell you something about urinary tract infections in chronic renal disease. Renal insufficiency is a great problem in the European countries, and we see that more and more patients suffering from renal insufficiency, and in this data from the European Dialysis and Transplant Association, you can see that a lot of patients suffering from interstitial nephritis and also from pyelonephritis. And the German register on chronic kidney disease reveals that 8% of people suffering from renal insufficiency have also an urinary tract infection. But the question is when the urinary tract infection in patients with renal insufficiency will be a problem. In general, single urinary tract infection does not cause end-stage renal disease. But in urosepsis, it's a life-threatening disease, or in patients suffering from diabetes or from glomerulonephritis, when they revealed also urinary tract infection, this kind of renal disease can altered the renal function and can lead to renal insufficiency. We know that various situations induce alterations of special intermediate processes. For instance, we see an accumulation of advanced glycation end products or an activation of proteinase K or for NF-kappa B, and these situations lead to an alteration of gene expression and alterate protein function. And this is responsible for cellular dysfunction and damages. And one example is that we can see in patients with renal insufficiency an alteration of polymorph-nuclear leukocyte function, leukocyte adherence, chemotaxis, phagocytosis, and we see also a decrease of antioxidant activity and also from disturbances of humoral immunity and T-cell function. These alterations are responsible for high risk of patients with renal insufficiency for urinary tract infections and also for respiratory tract infections and gastrointestinal infections, as well as necrotizing fasciitis or for diabetic foot syndrome. We know that also in patients with chronic kidney function, E. coli are the most microorganisms causing these alterations, but we see also that Klebsiella pneumoniae or Entecocci are also responsible for these diseases. From the investigation of pathogenetical processes in renal insufficiency, we know, as in other situations, that a microorganism which is able to induce infection have to reveal virulence factors. These virulence factors are adhesions, special toxins, and key and antigens. With the knowledge of the pathogetical aspects, we have a good situation for diagnostic assessment in urinary tract infection. We see the clinical evaluation by disease history or clinical symptoms. We have laboratory findings for urine analysis and also for evaluation of the infectious activity. And in some cases, we need also imaging techniques, ultrasound or radiological findings. The typical signs of urinary tract infection also in patients with renal disease are leukocytes in the urine and the bacteriuria. But we have to estimate special situations. For instance, in patients with renal insufficiency, urinary leukocyte count is broadly inverse to the proportion of the urine volume. In one side, we have during the kidney disease a decrease of excretion of urine, but we found a high increase of leukocytes. We see a hypoleukocyturia. It has two aspects. At first, we see that the excretion rate of urine is reduced, and so we have a concentration of leukocytes. And the other side is that in this situation, the uremic situation, cause an alteration of uroepithelial cells with a high excretion of leukocytes. Patients suffering from kidney disease has situation, they a lot of antimicrobiological substances, and so especially in patients with kidney disease, it's necessary that we analyze the microorganisms, and we testing the sensitivity of microorganisms and of the sensitivity of antibiotics and the evaluation of the resistance. But we see in kidney disease another cut-off value of significant bacteria. The normal situation, we have 10-5 colony-forming units. It's a criteria of Edward Cass, but in patients with renal insufficiency, the cut-off value for significant bacteria are 10-3 colony-forming units. And only in special cases with complications, it is necessary to evaluate the situation, for instance, by help of computer tomography to find obstruction or to find abscesses in patients with kidney disease. Now, the last part, I will tell you something about the treatment strategies because we have dangers to prevent a progression of the kidney disease, and we have to inhibit recurrence and resistance in these microorganisms. Naber have told us about the therapeutic strategies of acute cystitis. It was a nice talk, and I want not to say something about these strategies. A problem is in kidney disease, the pyelonephritis and the interstitial nephritis, because these are very problematical, because destruction of the tubular cells and also the glomerular units lead to a loss of kidney function, and so we have to estimate these interstitial nephritis and pyelonephritis, and we have to find the correct way. Choice of antibiotics in renal insufficiency depends from the severity of symptoms, from the causative microorganisms, especially from the data of their resistance and sensitivity. From choice depends from the state of renal disease and from the presentation of complication factors. We have a lot of good antibiotic substances for treatment urinary tract infection in patients with renal disease and especially in pyelonephritis, but we have also estimate that we have a high rate of resistance, especially for ampicillin or amoxicillin, and also we see it from cotrimoxazole and from the Fluoroquinolones example given here in this analysis with ciprofloxacin. And another point is also that the reduced glomerular filtration rate alterate the pharmacological data, and the elimination of these substances depends from the degree of chronic renal disease. You find it in the literature with a lot of lists with correct data for administration antibiotics, depending from the reduction of glomerular filtration rate. And in general, we can see antibiotics without reduction of doses in penicillin, ampicillin, amoxicillin, also ceftriaxone, but in these antibiotics we have a high resistance, and so I think it's not good to administer these substances when we have no microbiological data. And then we have a lot of antibiotics with a reduction of the doses depending from the kidney disease. And in patients with undergoing dialysis, we must estimate that a lot of the substances were cleared, but we have also a particular clearance and substances which are not cleared. And this depends from the molecular weight of the substances. It depends from the water solubility and from the protein binding, and also from the dialysis treatment. We have hemodialysis, hemofiltration, and peritoneal dialysis. And these factors estimate when we decide about antibiotic administration. Now I want to say that we have contemporary knowledge about pathogenetical aspects for diagnostic and treatment of urinary tract infection patients with renal insufficiency. But we don't know enough, and we need more and better studies, also an international collaboration to find more serious strategies for treatment. And when we see pathogenetical aspects, we have also conclusions for diagnostic and then for therapy. And I think it is necessary that we found together exact ways for better strategies to prevent the deterioration of renal function in these patients by urinary tract infections. Thank you very much.
Thank you very much, dear professor. It was a very nice presentation and informative. We are encountering serious problems in patients with CRF because many antibiotics require dose adjustment, and also many of these patients are suffering from other comorbid conditions that make the treatment even more sophisticated, and they are also prone to develop urosepsis and to become deteriorated during the course of the treatment. It's really challenging to treat the patients with CRF, and there was a point in your presentation that was really informative, especially for me, that we should define the urinary tract infection as more than 1,000 CFU, colony-forming unit, in patients who are receiving hemodialysis, in contrast to ordinary patients that we consider a cutoff as 100,000. That was very informative for me. So we should start the treatment earlier in these patients.
Yes, these are results from collaboration studies. You're right that it's not so easy in patients with a reduced excretion rate of urine to found the exact data for microorganisms, but these, I told you the data. We think that they are a good cutoff value for treatment of the patients.
And how about the use of aminoglycosides in these patients? Actually, these medications are nephrotoxic, and we should be cautious about using aminoglycoside in patients with CRF. Is there any indication?
Aminoglycosides we administered only in very critical situation, for instance, or sepsis also, and we don't administer aminoglycosides as a single antibiotics. We give it only in combination with other antibiotics when the clinical situation is very hard.
We are also worried about exacerbation or aggravation of the kidney function in patients with CRF. But I think in those who are suffering from ESRD, end-stage renal disease, and on hemodialysis, we can easily use these medications without any fear of aggravation of the kidney function.
Yes, you're right.
Okay, thank you very much. Next speech would be about the urosepsis. I'm really interested in listening to this presentation. Please start, Professor.
Okay, thank you very much, Dr. Faizabadi, Dr. Amini, for inviting me. It's a really great pleasure to give this talk. My topic deals with other types of complicated urinary tract infections and severe infections such as urosepsis. Now, Professor Fünfstück already has shown you the spectrum of complicated urinary tract infections. This also differs on the cohort of patients you look at. For example, this is the spectrum of our urological patients from our urological department. As you see, E. coli is still one of the most prominent ones, but we have a lot of other gram-negatives, a lot of enterobacteria. We have Pseudomonas aeruginosa, especially in those patients who have chronic urinary catheters. And we do have quite a number of Enterococcus faecalis. This has to do, to some extent, for example, patients that have bowel segments as urinary diversions and other very specific urological causes. Now, the complicating factors in patients with complicated urinary tract infections are very heterogeneous. You heard in the previous talk that renal insufficiency is one complicating factor. There are many others, and they can be grouped within a classification. You see here the so-called ORENUC classification. ORENUC is an acronym. It's the abbreviation of certain group factors. For example, we have extradural genital risk factors. That is diabetes mellitus. It is immunosuppression, for example, patients that have renal transplantation. And we have typical nephropathic diseases such as renal insufficiency. We have, on the other hand, very typical urological risk factors, for example, a urethral stone, urolithiasis. And then we have a large group of patients with urinary catheters, and that is, we see more and more patients with urinary catheters, chronic involving urinary catheters, and the ratio or the rate of patients having chronic catheters does increase. And the pathophysiology of catheter-associated urinary tract infections is different from the pathogen that causes this infection. For example, if you have Proteus mirabilis, that produce urease and split the urea, then you have a crystalline biofilm that eventually blocks the urinary catheter by acquiring ions, magnesium ions, and other ions. So this is a very typical pathophysiology we're all aware of. Patients usually have a high pH in the urine. On the other hand, for example, if you look at Enterococcus faecalis, this is a different pathophysiology because we have first a fibrinogen accumulation, and only then the Enterococcus faecalis can produce the pilus where they start the biofilm around the catheter. So if we want to prevent catheter-associated UTI, we probably have to go much more in detail into the pathophysiology of these different species-specific infections. And as I've said, catheters are very frequent. It is estimated that 15 to 25% of hospitalized patients have urinary catheters and up to 10% of nursing home residents. We know that catheters are often placed inappropriately. For example, incontinence is an inappropriate indication, and that physicians are frequently unaware. For example, in a large survey, more than 50% of physicians in the hospital did not monitor which patients are catheterized, and 75% did not monitor the duration or if the catheter could be discontinued, removed early. And that is certainly a large room for improvement. Now, complications by indwelling urinary catheter are manifold. We have the infection, the microbiome infection, we have the encrustation and the blockage of the urinary catheter, frequently and very rapidly leading to severe infections if external or internal catheters such as ureteral splints blocked. Urosepsis can ensue very rapidly. And then we have organ infection. We have, for example, in males, urethral dysfunction, urethral rupture. We have epididymitis, we have prostatitis. So the complications from catheters are quite significant, and in the systematic review, they have been quantified. If you have long-term indwelling catheters, you will find symptomatic bacterial infections in up to 100%. Mechanical trauma, more than 90%. We will have a blockage, encrustation. We have urethral stenosis, and so on and so forth. So the complications are quite significant. And therefore, for a long time, the catheter materials have been tried to be improved. And in the past, the readout, the primary outcomes have been very frequently bacteriuria. But as we now know that bacteriuria is not a very clinically significant primary outcome, because we have asymptomatic bacteriuria, for example, that does not even need to be treated in most patient entities. It is very questionable if this bacteriuria endpoint has any clinical meaning. And if we take this endpoint, yes, we can demonstrate that, for example, silver-coated catheters do have an advantage over normal catheters, but the question arises if this is really significant for the clinic. And therefore, one large study in the UK has been performed, where as a primary readout, symptomatic urinary tract infections have been measured. And as you see here, there was no difference between silver catheters versus latex catheters, and similarly, no really significant clinical advantage over antibiotic-coated catheters such as nitrofurazone-coated catheter versus non-coated latex catheter. So for the time being, what we are left with is to reduce the number of catheters or the length of the catheters. And that can be done by education. And we know that for a long time, there is a study that has shown that it is possible, a large study. Also from the US, there are other studies, for example, from the Netherlands. This is the large study by the US where almost 1,000 units have been included, and they have been trained, they have been educated at baseline and in the mean run over an 18-month interventional period. And then the rate of catheters and the rate of catheter-associated UTI has been assessed at various time points throughout this 18-month interventional trial. And the general result is that there was a significant decrease of catheter usage as well as catheter-associated UTI rates, but it was less than expected. So the decrease was roughly 2.8 to 2 catheter-associated UTI rates per 100,000 catheter days. And that is, for example, pronounced mainly in non-intensive care units, whereas there was no difference in intensive care units, which shows, and that was due to the fact that there was no decrease in intensive care units, which shows the fact that in intensive care units, probably there is no room to decrease catheters or decrease catheter length. Nevertheless, in non-ICU departments and non-ICU units, there was a significant decrease, and therefore this shows that education is something that has a room in improving catheter-associated urinary tract infections. So we have performed a systematic review over the last years to address certain answers for the questions. For example, indication for catheterization. Yes, it has a benefit to reduce catheterization indication. For example, incontinence is a very frequent indication. Usually the patient should not receive a catheter. Duration should be decreased. There is not enough evidence for the peri and post-operative catheterization. Apparently, at least there's no evidence that suprapubic catheterization would be much better in chronic indwelling urinary catheters with regards to UTI rates. And then for many questions, we don't have any evidence to give any recommendation. For example, clamping versus free urinary drainage, if there's a difference, irrigation versus no irrigation, antibiotic prophylaxis might lessen the frequency. On the other hand, we have an increase of antimicrobial resistances. Many other questions are unanswered. Antiseptic impregnated catheters certainly is very little evidence that it helps. And therefore, I think there is a lot of room to indeed improve the application of urinary catheters. Now, coming to urosepsis. I have depicted here a simple pathophysiology sketch of sepsis in general, which also holds true for urosepsis, of course. And there we have two pathways, if I want to say so. We have the external pathway. That means that the bacteria, usually the bacteria in urosepsis, and especially gram-negative bacteria, which harbor lipopolysaccharides, LPS, they release the lipopolysaccharide, and these lipopolysaccharide, by, for example, toll-like receptors, drive the inflammatory response. On the other hand, we also have endogenous substances, so-called alarmins. There are various of those substances, for example, mitochondrial DNA. And you remember that mitochondria by themselves, evolutionary, are bacteria, and they still have bacterial traits that are recognized by the immune system and might drive inflammatory response. And these alarmins, these endogenous molecules, are released by cellular necrosis. For example, if we do large operations in patients that have urosepsis, for example, and therefore we have two targets apart from systemic target to target with resuscitation methods. Two targets. One is the bacteria, for example, in urosepsis, and the other target is to prevent the formation of alarmins by preventing large operations. And therefore, as a rule of thumb, in a patient, at least in a patient with urosepsis, we frequently can do that. We should avoid large operations in the septic state and should only perform minimally invasive operations, such as ureteral stenting or inserting drainages whenever possible. Now, a big question is, of course, that we need to start management of urosepsis as early as possible. But for doing that, we need to diagnose sepsis and urosepsis as early as possible. And therefore, there are early clinical tools that have developed over the last 20 to 30 years, so-called early warning tools or early warning scores. One of the first of those tools was the systemic inflammatory response syndrome. That is now 20 years old, where we have 4 criteria, and if 2 or more of the criteria are positive, patients might have systemic disease. Then in 2006, early warning score and an update, the new early warning score has been invented, which is a more elaborated score where additionally to these 4 parameters, oxygen saturation, pulse rate, confusion, consciousness has been included. And 3 years ago, the so-called SOFA score, the sequential organ failure assessment score, was recommended to be used in sepsis, which is a very complicated scoring system addressing 6 organ dysfunction levels, and which is not very applicable to emergency units, for example, or normal units. And therefore, a spin-off of this complicated score, the quick SOFA score, has been invented involving systolic blood pressure, respiratory rate, and altered mentation. I must have said that these scores, especially the quick SOFA score, have never been evaluated for urosepsis. And we have started within the European section of infection urology a large prospective trial on urosepsis, and preliminary results show that this quick SOFA score is not as accurate for the take-up of urosepsis as it should. So which tools should we use? We know none of them short tools are accurate. Probably is the new early warning score is the better one because it's the more complicated score. And the early signals are best addressed with a new early warning score, even the systemic inflammatory response syndrome. So for the time being, there is for urosepsis no need to switch to the quick SOFA score. And if somebody is using the SEERS score still, it is certainly something that can be used. And we are currently in the formation and evaluating what the urosepsis study showed. But we do have additional biomarkers, for example. And procalcitonin is a biomarker that is certainly in routine in most departments already. Procalcitonin is a marker that is usually being expressed in the thyroid. But in septic patients, procalcitonin is also produced in other body cells, in other cells, because especially in gram-negative sepsis, the lipopolysaccharide is binding to the operon of the procalcitonin gene and is producing procalcitonin. And in this in this study, comparing only uroseptic patients, there is quite a nice correlation between procalcitonin and the severity of the urosepsis. On the other hand, we have a negative correlation between severity and platelet count. Therefore, if we have patients with a low platelet count, this is also something like a risk factor. But in general, procalcitonin is certainly something that can be done, or maybe should even be done, and it can point us to gram-negative sepsis. Another biomarker that is recommended also by the Surviving Sepsis Campaign guidelines that should be used is serum lactate. Serum lactate is not specific, of course, for infections. It is a marker mirroring the cellular homeostasis or the organ function or organ homeostasis. And in infectious patients with severe infection like sepsis, there is a high correlation or association between serum lactate level and mortality rate. And this is even higher, of course, where we have patients with septic shock. And if you have high lactate levels, higher than 4 millimole per liter, mortality of septic shock is still very high. So on the one hand, it's an indicative parameter to depict or diagnose patients with sepsis, also with urosepsis. On the other hand, it is a parameter that can be used to follow management success, because lactate should decrease, should fall within 12 hours at least by more than 30% if our management is correct. And of course, the antibiotic treatment is a cornerstone of treatment of urosepsis. And this is a study by our group, the European Section of Infection Urology, the Global Prevalence of Infection Urology study. And you see that there's a high rate of resistance in urosepsis. This is also very different from the different regions, from Europe to Asia to Africa to South America. And therefore, it is important that every unit has its own surveillance system to know which one is the best empiric treatment for patients with urosepsis. In general, we have certainly a quite number of antibiotics that can be used, but it would be very good to have clinical parameters, to have surveillance parameters, to have more detailed knowledge on what antibiotic is the best antibiotic to use. And of course, we could give carbapenems, which is still in most countries the most active drug. But then we have the problem that very soon we will lose these antibiotics due to resistance. And therefore, one should have a good picture of the susceptibility. For example, in our unit, we know quite well which antibiotics we can use, because even if you have ESBL bacteria present, our almost exclusive ESBL we have is CTXM15. And CTXM15, for example, is covered by Tazobactam. So in almost all the patients, we still could use piperacillin Tazobactam to treat urosepsis. So in summary, the treatment and the management of urosepsis is, of course, very complicated, and that is mirrored by the use of sepsis bundles. We need an effective focus control. Therefore, in order to know the focus, we need early imaging, and usually CT scanning is something that is very helpful in the first hours. And then, yes, we need to control the focus, but only minimally invasive in order to decrease the release of alarmins. And then in parallel or even early, antimicrobial therapy, adequate antimicrobial therapy is important, but before that we need to have microbiological sampling, urine culture and blood culture. And then it is important to know the resistant level of each unit. And then we have supportive measures. Volume therapy, steroids can be administered as early as possible. And catecholamines such as noradrenaline is the catecholamine of choice. All these other measures, such as adjunctive sepsis therapy, can be done, of course, but are more or less reserved for the intensive care unit, where a more detailed arrangement of the management of sepsis is performed. And these early management strategies are extremely important, because what we lose here, we cannot recover here. So with that, I thank you very much for the invitation and for listening to my talk, and we'll be open, of course, to address all the questions you might have. Thank you very much. I think you are muted, Professor Amini. I cannot hear.
Sorry, I forgot to unmute. Thank you very much. That was really informative and fantastic presentation about urosepsis and catheter-associated UTI. I wanted to once more emphasize that catheterization is really trivial in almost the majority of the patients and is not indicated for many patients that we usually use a catheter. Unfortunately, for many purposes that are not really serious, we use catheter. For example, for measurement of the output of the urine is a common indication in the hospitals that is actually unnecessary and harmful, of course, to the patients. We should avoid using catheterization to have fewer catheter-associated UTIs. Professor Naber, Dr. Ghiasvand, do you have any comment concerning these presentations?
No, I have no comments. And as you mentioned, this is very important to have the sepsis, prevent the sepsis is even more important.
Okay. Dr. Ghiasvand?
Yes, this lecture was really useful for me too. I'm infectious disease, but it's really novel. In our hospital in Tehran, we have a lot of resistance microbe because of use of antibiotics. In our hospital, we can use ceftriaxone, cefepime, or even tazocine for the urosepsis. Just we can use imipenem, carbapenems, or even polymyxins. Such as colistin, because we have a lot of Klebsiella pneumoniae that they are PDR and enterocoque, that they are VRE, vancomycin resistance, and it is a really catastrophic, I think, in all of the world. The message of the Professor Naber at the first presentation is, please don't use antibiotics without indication.
What did you say? Don't use antibiotics without what?
Without indications.
Yeah, absolute.
Yes.
Reduce antibiotic usage if wherever possible.
Yes, that's right.
And Dr. Ghiasvand, is there any stewardship program for prescribing antibiotics in our hospital in Tehran?
Yes, of course. We have a good plan for the stewardship antibiotic. Just the infectious disease professionals can prescribe the useful antibiotic and the necessary antibiotic for the patients that they have sepsis or the problem that they need. It's really important for us because I think if we don't we use the antibiotics more than before, we can treat the patients, and it's really important, I think.
Some surgeons or other clinicians sometimes prefer to prescribe more important, actually stronger antibiotics for their patients because they are worried about the actually complications after the surgery. Do you have any recommendation for them?
Yes, but it's not really necessary because all the patients don't need antibiotics. I will say about the asymptomatic bacteriuria. We know that we can have the colonization without any symptoms in the urine, and it's not necessary for treatment and empirical antibiotic therapy. And another things that you said about the surgery. All of the surgery don't need a prophylaxis with the antibiotics, strong antibiotics such as carbapenem. We can use the first generation of cephalosporin or third generation of cephalosporin just for prophylaxis. But I see that some surgeons use the carbapenems, unfortunately, and it's very bad. I think it's a big problem. And can be lead to the very big catastrophic too.
Yes, using imipenem and meropenem as prophylactic antibiotic is common in Iran, I think.
Yes, it's not correct.
There are some patients who have indwelling catheters for a long period of time, and actually they are suffering from asymptomatic bacteriuria, but prior to surgery, we need to treat them. And because of having long-term indwelling catheters, they are actually infected with bacteria that are resistant to most of the antibiotics. How about these situations? We should treat based on antibiograms, yeah?
Yes, I will say about it. My lecture is about this ASP, and I should say that in this patient, we don't have any way to treat this patient. We have to use the appropriate antibiotic to these patients.
Because we are really worried about the urosepsis during the surgery or after the surgery in these special cases.
Because the mucosal trauma.
I look forward to hearing your presentation. You can start.
Thank you very much. Okay. Hello, everybody. I really thank Professor Fereshteh and Dr. Amini for inviting me to these panels. I'm Dr. Fereshteh Ghiasvand, Assistant Professor of Infectious Disease of Tehran University of Medical Science. My lecture is about asymptomatic bacteriuria. I don't know how can I... Yes. As we know, asymptomatic bacteria is a common findings in the population, including healthy women and persons with underlying urologic abnormalities. Antimicrobial treatment of ASB has been recognized as an important contributor to inappropriate antimicrobial use, which promotes emergence of antimicrobial resistance. Asymptomatic bacteriuria, or ASB, is the presence of one or more species of bacteria growing in the urine at a specified quantitative counts. It means that more than 100,000 colony-forming units, irrespective to the presence of puria in the absence of signs and symptoms attributable to urinary tract infections. For women, 2 consecutive specimens should be obtained, preferably within 2 weeks, to confirm the presence of bacteriuria. But for men, a single urine specimen is sufficient for diagnosis. For some population with high prevalence of ASB, such as patients with chronic indwelling catheter, older institutionalized population, patients with spinal cord injury, and some persons with diabetes, immunocompromised patient, and etc., treatment or screening of ASB is challenging. In this lecture, I want to start my speaking with some questions. I want that audience please take part and answer my question if it is possible. The question 1, a girl 3 years old with history of VUR, vesico-urethral reflux grade 2, comes to clinic because of urine culture positive with E. coli without any sign and symptoms of UTI. What is your approach?
My answer would be, why did you check the urine at all?
Yes, the correct answer. So it's not necessary. It's not necessary, but unfortunately, most of the physicians check the urine culture in these patients. In the pediatric patients, evaluation of benefits and risk of detection and treatment of ASB in children poses unique problems. ASB is common in infants and boys and occurs in about 1% healthy girls. While there may be an increased risk of symptomatic UTI bacteria in children, there is no evidence a higher risk and subsequent renal scarring and, of course, renal insufficiency.
Dr. Ghiasvand?
Yes,
that's the answer.
I'm here.
Actually, we are worried about breakthrough infections during treatment of the reflux. Many of these patients are on prophylactic antibiotic up to 5 or 6 years of age to prevent breakthrough infections. But sometimes even on prophylactic antibiotics, breakthrough infections might happen. That would be an indication for surgery of the reflux. Should we consider asymptomatic bacteriuria as a breakthrough infection, or we should not pay attention to it at all?
That's important.
No, it's asymptomatic bacteriuria. It's not a breakthrough infection. It didn't lead to breakthrough infection. But if you want to have a urologic procedure, it's another discussion. I will say it in the next. It is the indication for using the antibiotics.
Actually, if we do not consider ASB as breakthrough infection, it's not necessary to do any intervention for such patients.
Yes.
Thank you.
You're welcome. In the British cohort, a school girl cohort, a non-randomized open-label control trial of antimicrobial treatment for 7 to 14 days in about 100 of these girls with ASB reported no differences in subsequent symptoms of UTI, resolution of VUR, kidney growth, or renal scarring in treated or untreated girls. It's really important. So in infants and children, recommendation is against screening for or treating ASB.
Wonderful.
Yes. And question 2, we have a 34-year-old woman with history of diabetes is referred to clinic because of urine culture positive with enterococcus fecalis in 2 consecutive specimens without any sign and symptoms UTI. What is the approach?
Even don't tell the patient.
Yes, don't do anything. Don't do anything. There's a good study with diabetes mellitus that there is no benefit if you treat them with the asymptomatic bacteria. You have only, as a result, more resistant pathogens. And there's another study by our friend Tommaso Pai, who even showed that these patients, especially if they have Enterococcus faecalis, if you treat, might even have a higher rate of symptomatic infection, because sometimes you have beneficial bacteria that contribute to the personalized microbiome.
Yes, of course, the very good answers. I
had a similar patient, and it took time for me to convince her that you do not require any antibiotic therapy. She was really anxious about the results of the urine culture.
Yeah, that's true.
Yes. ASP and healthy non-pregnant women, one study revealed that there were no differences in the frequency of subsequent UTI during 1 day of follow-up after treatment of bacteriuric women with a 1-week course of therapy with nitrofurantoin or placebo. There is some evidence suggesting that persistent ASP may protect from symptomatic UTI.
That's very important.
And yes, an early randomized trial of therapy for women with ASP reported that most symptomatic reinfections occurred in the antimicrobial treatment group, suggesting that treatment of bacteriuria may be associated with an increased risk of symptomatic UTI. Although women with ASP may also be at increased risk of symptomatic UTI, ASP, even when persistent, appear not to be associated with other adverse outcomes, and there is no evidence to suggest that episodes of symptomatic UTI are attributable to the ASP. Moreover, treatment of ASP may not decrease the frequency of symptomatic UTI, including pyelonephritis, and antimicrobial antibiotics may increase rather than decrease the risk of subsequent UTI. So, in healthy perimenopausal non-pregnant women or healthy postmenopausal women, recommendation is against screening for or treating ASP.
Yeah.
And about the diabetes patient, our colleagues said about that. In the past, the diabetes patients should be screened for the asymptomatic bacteria and should be treating. But nowadays, it has changed. Antimicrobials may not reduce the risk of symptomatic urinary tract infection in these patients. Men with diabetes were included in only 1 cohort study and outcomes were similar. And patients with diabetes, recommendation is against screening and for treating ASP. Question 3. A pregnant woman, 25 years old, gravid 2 para-1 with 14 weeks of her gestational age comes to clinic because of urine culture positive without sign and symptom of UTI. It's a simple question. What's the approach?
That is the most discussed question now in Europe. Well, how to handle, how to handle asymptomatic bacteriuria in pregnancy. And we just with Florian also and others from Norwegian, we wrote a paper. We said, yeah, screening may be okay, but treatment is something else. Screening may be okay that you know what is going on, but treatment is something else, whether you treat or not.
Probably in near future, the guideline will change, and they will recommend not to treat pregnant patients with asymptomatic bacteriuria, because most of the trials and studies are related to very old age, before 2000, I think.
That's one thing. And the other thing is, you treat, usually you will detect it in the beginning of the pregnancy, and then you treat with antibiotics. And of course, these women will have a higher rate of all women will have in pregnancy will have a higher rate of pyelonephritis later on in the third trimester. And then probably you have selected resistant pathogens, and then the treatment of pyelonephritis becomes more difficult.
And species that result in asymptomatic bacteriuria are hypothesized to be even useful in some cases.
Pardon me, I did not get your comment.
Yes, thank you for comments.
Okay. I meant species that exist in asymptomatic bacteriuria may be even prophylactic, may be even useful and prevent more serious infections.
Yeah, but
you're right.
Not in pregnancy. We have no study in pregnancy.
Yes, I agree.
Of course, please careful. ASP maybe protect the non-pregnant women from the symptomatic UTI, but in pregnant women, it's different. It's really important because ASP occurs in 2 to 7% of pregnant women. Antimicrobial treatment decrease the incidence of pyelonephritis from 20% to 1%. It's really significant. And some studies also reported that decreased treatment of ASP can decrease the labor's weight and premature labor. It's important. So in pregnant women, recommendation is a screening for and treating ASP. Urine culture is, yes, it's based on the American Society guidelines and researcher review. Yes, urine culture is suggested to collect it at first of the initial visits early in pregnancy. There is insufficient evidence to inform a recommendation for or against repeat screening during the pregnancy for a woman with an initial negative screening culture or following treatment of an initial episode of ASP. That's right. And in pregnant women with ASP, suggestion is 4 to 7 days of antimicrobial treatment rather than a shorter duration. It means that in the uncomplicated cystitis, we use a single dose of such antibiotics such as fosfomycin, but in the pregnant woman, we should use 4 to 7 days of antimicrobial treatments. Question 4, a man 32 years old, case of kidney transplant from 3 years ago is referred to clinic because of positive urine culture and without symptoms. What is your approach?
Rainer, it's your turn to answer. Rainer Fünfstück.
I can't understand.
He doesn't say anything. We need the nephrologist should answer.
I think it's depends from the kidney function and from the function of the kidney transplant organ. In general, I think I do not treat an asymptomatic bacteria in patient after kidney transplantation.
Yes, very well. ASP is common in following renal transplantation, and symptomatic UTI is the most frequent infection identified in these patients. Unique outcomes of concern potentially attributable to UTI include graft loss, acute graft rejection, and impaired long-term graft function. The impact of UTI may be more severe in the immediate post-transplant period. I mean that within the first month, when patients are at highest risk for infectious complications because of exposure to new and more intensive immunosuppressive therapy, indwelling urologic devices, and urologic interventions. A prospective study in children with a renal transplant reported that 39% of these patients had at least one febrile UTI, and while graft function worsened during the febrile episode, there were no differences in graft function at 2 years for those with and those without febrile infection. Treatment of ASP in renal transplant recipients for more than 1 month after surgery may not prevent pyelonephritis or graft rejection. Antimicrobial resistance organisms are common in renal transplant recipients, and high proportion of resistant organisms causing ASP may not effectively treated with oral therapy. Treatment of ASP probably promotes reinfection with organism increasingly resistant to antimicrobials, potentially compromising treatment of symptomatic UTI, which is also frequent in these patients. So, in renal transplant recipients, recommendation is just for the patients had surgery less than 1 month after the transplant, and for more than 1 month, recommendation is against screening for or treating ASP. And about other solid organ transplant other than renal transplant, in the past, recommendation is for screening and treating ASP, but nowadays it's changed. UTI are uncommon in non-kidney solid organ transplant, and evidence suggests that serious harm resulting from symptomatic UTIs are extremely rare. Any serious adverse consequence of ASP in non-renal transplant recipients would be even more uncommon than symptomatic UTI. So in these patients, recommendation is against screening for treating ASP. And we should be careful about the antimicrobial resistant organisms and even Clostridium difficile infections. So in the solid organ transplant and other immune compromised patient, recommendation is against screening and treating for ASP. And just for kidney transplant, the strong recommendation is for the patient at the first month after transplantation. And question for, I don't know how many times do I have, Dr. Amini?
I think we can continue for more 5 to 10 minutes.
Okay. Question 4. A man, 32 years old, case of acute lymphoblastic leukemia, referred to a hospital. His last chemotherapy was 2 weeks ago. And he doesn't have any symptoms and sign of UTI. Her WBC is 1,100 and PMN 500 per microliter. UC is E. coli, resistance to ciprofloxacin, ceftriaxone, sensitive to imipenem and gentamicin. What is your approach? I can't see the answers of the audience. Dr. Amini, can you see?
Difficult. I don't know.
Well, I mean, there are no direct symptoms, but you have increased or elevated. I mean, this is a leukopenic patient, and if he is febrile, for example, that would also be a symptom.
Yes.
And therefore, sometimes it is really difficult to differentiate between asymptomatic bacteria and a symptomatic infection, even if they have no typical urinary tract symptoms. In such a patient, probably an antibiotic treatment could be indicated.
Yes, you're right. We have to, I'm sorry.
Yeah, difficult case. Difficult case.
I'm really sorry. I had COVID-19 in 2 weeks before, and I have cough now. Yes, I'm really sorry.
Oh.
I have fever now. In the patients with high-risk neutropenia, I mean that's the absolute neutrophil count less than 100 cells. There is no clear recommendation for or against screening these patients. These patients, I don't know why my slide don't change. This patient then have fever. We should use antibiotics for prophylaxis, such as Quinolone or cephalosporins. But if they don't have fever and just have a urine culture positive, it's not necessary for treat these patients. And in low-risk neutropenia patients, it's not necessary to screening and treating the ASV. I don't know why I can't change my slides.
Can you close the slides and reopen it?
Yes, stop share and again. Okay. Sorry.
I also have another scenario, and I would like to ask you about this scenario. Some patients have indwelling Foley catheters, for example, for 2 weeks or 3 weeks. And after 2 or 3 weeks, we decide to withdraw the catheter. Of course, after removing the catheter, there would be bacteriuria. Undoubtedly, there would be bacteriuria after 3 weeks. And the patient is currently asymptomatic. Should we treat this patient, or we should stop until the symptoms occur and then treat the patient?
You mean that when we want to remove the catheter, we should use the antibiotics or not?
Yeah. In a patient who is going to be catheter-free, not in a patient who is presented for exchange of the catheter. For exchanging the catheter, I'm sure that it is not necessary to prescribe the antibiotics.
Yes.
But in a patient who want to become catheter-free, should we treat the patient to prevent symptomatic bacteriuria in near future?
No. It's not necessary.
Yeah, I don't know. Okay, we have done it for a long time in the hospital. That was somehow routine. Take out catheter, give only one dose. That's what you are asking. But maybe this is the urologists are afraid. But I don't know a study on that. Maybe you have a study on that. That would be interesting.
I personally prescribe. I usually prescribe because I want it.
Yeah, now I cannot hear you.
I'm really sorry because of my systems had a problem. I don't know how can I.
Sorry, may I help you, Dr. Ghiasvand?
I escaped, but I can.
Dr. Amini, we cannot hear Dr. Amini.
Yeah, maybe you should get out of the full screen mode and then share your screen by PowerPoint.
Yes, but I cannot find it. Do you have my slides?
No, not yet.
Okay, I can. I don't know how.
Another question is about the definition of the asymptomatic. How should we define the asymptomatic? Maybe your questioner can help us, Professor Naber.
Dr. Amini, I'm sorry. I'm really sorry for this problem. I have to out and then come back to the Zoom.
Okay.
Yeah, I have not seen a good study on that, but we did the same because you said, okay, 1 dose. Oh, okay.
Some patients may actually suffer from vague pain in the abdomen or some symptoms that are not directly related to the urinary systems. I'm not sure if we should consider them as symptomatic or asymptomatic, because some symptoms we cannot be sure that are directly related to the urinary system.
Absolute, you're right. Kind of endoscope. Okay, endoscopic, yeah, it's also good.
Is it okay?
That's a good.
Yes, okay. Question 6. I'm really sorry. What is the best approach to patients candidates for endoscopic urologic procedure and asymptomatic bacteriuria? Do you recommend screening ASV before procedure? And if it is positive, what should we do?
Okay, here we have in the guidelines, in German guidelines, or I usually say, as long as you are not an traumatizing urologist,
what?
you don't need to give an antibiotic. I say, however, of course, if you do any intervention, then you have to give. But if you do not give, you are not a traumatizing urologist. But of course, some procedure is traumatizing.
But there are not so much non-traumatizing.
Not so many.
You should. I think the urologists use a lot of antibiotics before their procedures. Am I right?
Yeah, but for a normal cystoscopy and so on, is it needed? Maybe not. Maybe not. If you do it very gently.
Cystoscopy is really low risk for the bacteriemia.
Low risk,
it's
yeah.
not necessary.
If there is no mucosal invasion, we can stop prescribing prophylactic antibiotics.
That's true. I think the invasion is correct. I usually like traumatizing.
Yes, and the patients who will undergo endoscopic urologic procedure associated with mucosal trauma, recommendation is a screening for and treating ASP prior to surgery. And individuals with bacteriuria, these are procedures in a heavily contaminated surgical field. High quality evidence from other surgical procedures shows that preoperative antimicrobial treatment or prophylaxis for contaminated or clean contaminated procedure confers important benefits. In patients who will undergo endoscopic urologic procedure, suggestion is that a urine culture be obtained prior to procedure and targeted antimicrobial therapy prescribed rather than empirical therapy. In patients with ASP who will undergo urologic procedure, suggestion is a short course.
Sorry,
one or two doses.
I'm so sorry. We cannot see your slide.
We cannot see the slides, yeah.
Yes. Oh, sorry, I don't know what's the problem.
Don't hide your slides.
No, I don't want. It was good. I don't know what's the... I share it again. Is it okay?
No.
Not yet.
No, bravo, bravo. Now I can see.
Is it okay?
Yes.
You can see?
Yeah.
Okay, sorry. In these patients, we suggest that a short course of antibiotic, 1 or 2 doses, rather than more prolonged antimicrobial therapy. And antimicrobial therapy should be initiated 30 to 60 minutes before the procedure. It means that it's not necessary that we use prolonged empirical antimicrobial therapy. And it's a really important note is that it's not necessary that we sterile the urine before the procedure. If you use the short course of antibiotics, it's enough.
Correct.
And about the patients planning to undergo surgery for an artificial urine sphincter or prosthesis implantation, there is no suggestion for screening or treating ASP. All patients should receive standard preoperative antimicrobial prophylaxis prior to device implantation. In patients living with these implant urologic devices, screening is not suggested. And in the patient with indwelling urethral catheter, in the patient with short-term or long-term, we don't have any recommendation to screening or treating ASP. And about the patient with suprapubic catheter, the recommendation is similar. Thanks a lot for your attention, and I'm really sorry for that problems.
Yeah, okay.
Thank you very much.
Thank you.
Very nice presentation.
A very good literature overview. Excellent.
You're welcome.
Yeah. Okay, I'm one general comment. Nowadays, we know that in each bladder or urine, we always have bacteriuria. We always have microbiome. We have a microbiome, and whether 10 to 5 is the right threshold or 10 to 4, nobody really knows. And whatever we do, we give an antibiotic against E. coli, but this antibiotic has also activity against many other bacteria in the microbiome. And so we will shift the microbiome. And maybe the balance, this is what prevents from infection. And as soon as we disturb the balance, then we have a problem. It's like in politics, it's the same. As soon as the balance is disturbed, we will have fight.
Yes.
Or infection, you can call it whatever you want.
Yes.
Thank you.
Thank you very much.
Thank you for your comment. Any comment from other speakers? Dr. Faizabadi?
No comments, but I would like to thank the colleagues, friends from Germany, my colleagues at Imam Khomeini Hospital Complex, where Professor Naber gave presentation at your department, I think 2 years ago before going to Kerman. For me, it was very good, and I received a private message from my colleagues, the professors. They are very happy with the quality of the information you provided, and I hope to have a true meeting, not virtual one, in the future, either in Tehran or I don't know,
Germany,
Gießen or Munich or Professor Reinhard City. So we are ready to continue such programs on the behalf of Tehran University of Medical Sciences in collaboration with other departments. And I would like to pass the appreciation and thank of our seniors at the university. They will issue certificate signed by Vice Chancellor soon, so I will forward it to you. And that's it. Thank you very much. And we will be in contact with you for collaborations and also for other interested areas. I am in particular microbiologist. Personally like to use the new techniques that you have in your departments for, as a professor stated in his slides, next generation sequencing also is highly demanded because we have a lot of isolates from patients with COVID-19, for example. We would like to analyze them on the selected strains, particularly. Klebsiella pneumonia is very, very bad bugs in our hospitals. So we characterize them by phenotypic tests and some genetic tests, but we would like to continue to share the information with our colleagues and hope to exchange more experiences and knowledge in the frame of webinars or seminars, or as we talked together at Munich last time, arrange a joint meeting with universities in the south of Germany and also with Tehran or other cities. I am sure that many people are interested from both sides to collaborate. And thank you very much.
We thank you. We thank you very much. Thank you.
Thank you very much. The interest is really on our side. Thank you. It's a pleasure.
Bye. Thank you for inviting us.
Thank you very much.
Bye. Goodbye.
Keep day job.
Okay, bye-bye.
Okay.
Bye-bye.
Bye-bye.